Foundation Trust. I'm delighted to have so many governors joining me today, and members of the public who may be watching this in the future. We have quite a big agenda today as ever, so I will try and keep us to time and moving forward appropriately. We have some apologies for absence. We have Roger Weddell, Phil Gilbert and Yasmin Becker having given formal apologies. Sarah Collette, are there any other apologies you're aware of?
Sorry, did you say Jane Knight? I was just checking the choracy, but you did, yeah, no more apologies, and we are quorate. Okay,
sorry, I didn't mention Jane Knight, but thank you, Sarah. So we're quorate, so we're ready to rock and roll. Thank you in particular to staff governors who are giving up their time today from their busy work. And it's great to welcome Bernard Osselman as one of our new staff governors. Bernard, we greatly appreciate you joining us and giving up your time to be part of the staff side voice on the council. And it's also wonderful to welcome back Fiona Burton as our Chief Nurse Officer. Fiona, we've missed you and it's good to have you back. But thanks again to Sarah Moffat for all the work she's been doing whilst you've been on necessary leave. Have we any new declarations of qualification for office or declarations of interest? Could you please raise a digital hand if so? Sarah?
Thank you, Russell. The updated declaration of interest register is on the agenda today, but in addition to those listed, Pat Scott has submitted an updated declaration, which is that her grandson is a physiotherapist at the Trust and her daughter is a primary care network manager in Coventry. So just those additions to note, please.
Super, thank you very much. Thank you for that, Pat. Any other points on that item? Okay, we'll duly move on then. So we've got the minutes, the meeting held on the 9th of February. If there are any points of accuracy on those minutes, could you please raise a digital hand? Okay, I can't see any digital hands raised, so I'll take them as accurate and duly sign them off. So we'll then go to page 20 of our pack for the action points arising. The first was on the annual review of committees' terms of reference for the patient care committee, for that to be amended and duly circulated. That was done, Sarah. Thank you very much. Then we had the South Warwickshire Place Plan to be circulated to governors. I believe that was done by Anne. Thank you in abstention, Anne. Then on the operational assurance report, the group research strategy to be circulated to governors, and I understand that was done as well. Then on the patient experience assurance report, a more detailed narrative provided in the next report about the type of subjects identified as other in the powers section of the report. If you can pick that up, Fiona, going forwards, that would be great. Thank you. Then on the elective care group, details of the 7 key risks referred to in the report be shared with the public governor, CH. I'm terrible sometimes on remembering everyone's, so I'm just wondering who CH was.
That's Callie.
Thank you. Callie, thank you very much. Graham, were you able to do that?
Yeah, I sent it to Callie, the actual risk report. Okay,
super. Like the little beard, Graham, last time I saw it, I don't quite remember that, but afraid
it's a midlife crisis thing. I'm going to see if I can get it too plat.
Good luck with that one. And then on the local quality indicator, I believe that was discussed and is happening. And then finally on the General Purposes Committee draft minutes, draft email for recruiting new members to be circulated to governors, and Mary, I think you did that. So
yes, and we're waiting for further information when we've got the new membership and engagement group set up to how we're going to progress those issues.
Super. So are there any matters arising the colleagues feel we haven't covered? And can't see a digital hand, so I will move on. So Then on the so-called chairman's remarks section, I've included an update on the last integrated care partnership, which I will take as read. These meetings occur every 3 months and bring together a very broad church of partners across Coventry and Warwickshire. A good level of debate. I don't sit on the Integrated Care Board, but I do sit on the Integrated Care Partnership Committee. And one of the key things to come out of that was that I am concerned that we need to ensure both at the Integrated Care Partnership, the Integrated Care Board and the SWIFT Board, the patient voice sufficiently and citizens' voice sufficiently loudly. So I have asked Chris Bain of Health Watch Warwickshire to, on a regular basis, come to the SWIFT board workshop to update us on issues which are of concern based on Health Watch's work for the citizens that we all serve. And Chris has agreed to do that. So thank you to Health Watch Warwickshire for supporting us in that. Any questions on the rest of that report which I can help with? Please raise a digital hand. Okay, so on the basis I can't see any hands raised, I'll move on then to the assurance item and assurance items. And the first are those governor requested assurance issues. And I think the first, Glenn, was, and it's over to you, but you're going to include the consequences of the junior doctors' strike. So Glenn, over to you.
Yeah, thank you, Russell. What I was going to do is just a very brief operational update and also specifically talk about the impact of the strike. So I'll probably just do it in that order, which is, if that's okay. So from a performance-wise, it's been a really difficult period because of lots of things going on, including high levels of demand, but also the strikes, which I'll talk about in a moment. In fact, if you look at our demand, so last week was, we've had our highest number of A&E attendances ever, 298. So that's higher than we had in the kind of December peak. And I look back on too many years in the trust, but I remember when I first came, 150 was a big number, and now we're going to go above 300. So, and that's daily attendances in A&E, and that's at a time when actually probably the acuity has got slightly higher as well, because we're doing a lot of other things outside of hospital. So that continues to be challenging. Despite that, we've been performing well. A number of changes that were made to flow. We did some improvement work around the way our same-day emergency care works. So year to date, we are just the right side of 80% of A&E for our standard, which is considerably higher than most other trusts and exceeds the standard that we're supposed to get to by the end of the year, which is 76%. So long may that continue. Elective activity continues to be good as well, and protecting elective capacity. We delivered the 78-week waiting time challenge for the NHS at the end of the year. The NHS is now focused on 65-week maximum by the end of this year, and we see no reason at all why we shouldn't get to that. We've also been invited to take part in an outpatient stretch exercise, which is to see if some of those waiting lists that are involved in outpatient activity, which is about 75% of the total waiting list, is non-admitted pathways, whether we could get there faster in terms of 52-week maximum. So we'll be hopefully getting some extra resources and help to do that over the summer. And linked to that, obviously, our elective hub work starts with the front door project. And if you hear any noise behind me, and if you've been on the site recently, you'll know there's quite a lot of enabling work started on that. And today, because it's Super Stats Day for the NHS, there's a bit of a feature. So our old friend Michele Paduano from BBC Midlands today has been on site doing a little piece about elective recovery, talking about the work that's going on here. So it should be positive, but you never can be too sure. So that's all good. Surgical robot arrived a few weeks ago, which will initially be being used by the colorectal team, but will be supporting gynae as well and other specialties moving forward. And that's been quite an important thing to implement at Warwick, particularly around recruitment and retention of surgeons and training of future surgeons. And I mentioned training yesterday. We had the official opening of Acorn House. I think Mary and was there. I don't know if there were other governors there, but I didn't do a full look around the room. But that was fantastic to see that facility coming to life. Great facility, but a really great team working in there, training all sorts of disciplines of staff. So that's great, and it's obviously a stone's throw away from the site, which is also good. At the start of the week, we had a group-wide nursing conference as well in Bromsgrove, where representatives, nursing and midwives conference, where representatives across the group talked about some of the improvement projects. Jean was there for that, and Russell and I had an opportunity to say a few words as part of it. That was a really great event, and kind of demonstrated what we're all about as a group, which is sharing best practice at pace. Next week, we've got an improvement conference, which is a virtual event, again going on across the group. But one or two people have also asked if they can join that from national colleagues as well, because they're interested in what we're doing. All of that performance stuff all wrapped up has left us in a situation where we're still in segment 1, which is the best segment in terms of our overall performance. As yet, they haven't factored back in to that financial management, but they will be quite soon. So it's really important for us, and Kim will give you an update on this later, really important for us to continue to manage the resources in the way that we have here, and have a reputation to. Got a challenge this year in terms of our cost and productivity improvement plan, but it's really good that we're doing that through the lens of quality. So we're doing this Excel in Everything program, which will deliver efficiency, but also make improvements to patient care. And we've had a couple of inspections over the last few weeks as well of maternity. That you don't seem to get past a month without another inspection of maternity services these days. So we've had an Ockenden review, which was a system and a regional inspection. And we've also had the CQC in to look at our maternity service. Good feedback from both. We'll get a formal report back from the CQC, which we'll obviously share in our next public board meeting as soon as we've had it. And then also celebrations are being organised for the 75th birthday of the NHS in July. So we're starting to look at what we do there. And what we'll try and do there is look back on some of the innovations that we've implemented locally over those many years, and also celebrate some of our staff that have been with us for a long time, including a certain chief executive. Well, we won't celebrate him, but I've been here it'll be 40 years this year. So it's a 75 for the NHS, 40 for me. So and the NHS looks better than I do. So let's just go back to the junior doctors strikes issue. So there's been a lot of focus nationally on cancellations, but what I've tried to encourage people to look at is the levels of activity that took place over those strike days, because a lot of organisations actually cancelled or didn't plan to do activity in advance. So cancellation, you can only cancel something you plan to do, and many didn't plan to do it in the first place. But what I'm pleased to report from our perspective is through an awful lot of effort from lots of people, we cancelled very little and reduced our activity very little over those 4 days, which were really quite challenging. So we dropped around 176 outpatients, which over that period of days is quite a small number, and certainly one of the smallest in the NHS. No inpatients were cancelled whatsoever, and only 6 day cases were lost, and that was because of consultants who visit us from UHCW not being available during that period. So how do we do that? We did that through an awful lot of planning and coordination, through consultants working really hard, and dropping some of their other activities to be on the front line, and other disciplines like advanced clinical practitioners, and everyone pulling hard in the same direction to deliver that. So but I wouldn't want to give the impression that it was easy. So I did actually visit the picket line that was outside my office. And I think one thing, and talking to them, they're quite resolute about the need to address resource issues. It's, this is obviously a little bit more than just a pay dispute. but it's not, this isn't a dispute between us and our workforce. This is a national issue, and so that's why I was keen to ensure that we got back to business and work with each other moving forward, which is what we've been able to do. There is the mandate exists until August for further strike action. At the moment, junior doctors have not indicated any further dates, but there still is a risk that there could be coordinated action with what could still be a potential nursing strike. So the Royal College of Nursing are voting again at the end of this month to consider whether they should take out further action. And you'll be aware that some of the other unions have agreed to the pay rise such that it is actually going to be enacted. So the government are saying June, but they've not given us the details of it yet. But June, July time, we will be making the award to all of those agenda for change staff groups, even though the RCN have not supported that payment yet. And so we obviously wait to see what happens with those national discussions. I think the biggest concern for me is over the last 3 years, we've been on a kind of an incident footing for too long. And so the amount of management headroom and capacity that goes into planning for responding to strikes is significant, and it stops us doing some of the other things that we want to be doing, improving services, delivering some of those improvements I've already touched upon. So the sooner we can clear the way, get that headroom back, the better. So hopefully, Russell, that touched on what the governors wanted me to touch on. I'm happy to take any questions.
No, thank you, Glenn. I mean, we are still recovering, I think it's fair to say, from the challenges of the winter, COVID, and as you say, the different disruptions that we've had. And whilst our performance isn't quite where it was in 2019, I think our journey of improvement is faster than others. So I would just like, before I invite governors for questions, to thank the executive directors and all of our frontline teams for the work they do day in, day out under very stressful circumstances. And as Glenn indicated, at a time where there is real anxiety in terms of cost of living and the practicalities of life. So thank you. Questions and perspectives to Glenn. Could you please raise a digital hand? Bernard?
Yeah, thank you. I don't know if you can hear me. Can you hear me?
Yeah, marvellous. Perfectly, Bernard.
Thank you. So, Glenn, as you know, we're somewhat reluctant in the medical profession to call it a junior doctor strike, because some of the people on strike were actually fairly senior, well qualified, well experienced, and propping up the NHS left, right, and centre, as you might expect. But my question is about future strike action. I mean, as far as you can read the runes, what do you think the likelihood of a consultant strike might be over the next 6 months going forward?
Well, Bernard, I might ask you that question, but yeah, as you're aware, the BMA is putting out a vote to its members about whether consultants should take action. I think one of the issues that has been quite rightly concerning consultants has been some of the pension flexibility, the lifetime allowance arrangements, and it was pleasing to see some resolution to that within the last budget. So I think that's one issue that might well help the mood. But I think the concern, as you say, from junior doctors, and these are senior doctors, these are some very senior clinicians, a concern from them is kind of wider than just their own pay. It is about the workforce gaps and the pressures within the NHS. And one thing that we've not seen yet, and I hope we see very soon, is the National Workforce Strategy. And what I would hope is that if we can get that out soon, and it has the right elements of it, including training more doctors and resourcing that appropriately, that it might give us some more guarantees that appropriate resources are going into this, because it is about some of the pressure that some of those individuals are under that is leading to this. yeah, I hope there's a resolution. I hope we get to a position where the resources are there and we can move forward positively. So, but don't ask me to give a percentage on my confidence on that one, please, Bernard.
Okay. Yeah. All right. Thank you.
Thank you, Glenn. And Sue?
Oh, yes, a couple of things. Thank you very much for Acorn House. I was going to say it is a lovely place, but thank you on behalf of the community staff based at Cape Road, who now have a nice, beautiful offices to be in, both the district nurses and the therapy staff and health visitors. But thank you for that. And the other thing, very briefly, is from an RCN perspective, I'm glad you realise that obviously it's not a protest against the trust. We have no conflict with the trust at all. This is a national issue, and yes, it is to do with pay to a slight extent, no, probably more than that actually. But unless we get a decent salary for nurses, we're not going to be able to get the nurses into the profession. And what we're fighting for is safe staffing levels.
Yeah, I completely understand that, and so actually one of the things I think needs to be considered in all of this is the headline pay rate. If it does address the recruitment and retention issue, will not be as high as it looks, because obviously the use of agency staff is a problem right across the NHS. So if we can do something that slows that down or reverses that, then it actually will save us some money. So I think that needs to be taken account of. And as for the district nursing, the community staff that are based within Acorn House, I visited them in the height of last summer when it was really hot, and they'd got a lovely air-conditioned office, which was so tempting to stay in there. But it was such a great facility compared to where they were before. So I'm glad that that's been well received by them. Thank you.
And any other questions or perspectives? I think, Glenn, just going back to what you referred to regarding the building works outside, I would just like to say to members of the public, patients, their families and loved ones visiting the site, and this summer in particular and this year is going to be even more difficult in terms of car park logistics, because of the fantastic building work that's going on to redevelop the site. So we do apologise in advance. Everyone who visits the sites knows the practical challenges of finding a car parking space. So all we can do is to get the work done as quickly as possible, and apologise to patients, families and loved ones, as well as members of staff in the meanwhile. We'll move on then to the patient experience assurance report. And Fiona, welcome back. Over to you.
Thank you. So this report is a summary of the quarter. Information related to the last quarter. So in summary, for the members of the public, I think the governors hear this on a regular basis, so should be no surprises to you. So in that quarter, the number of complaints and concerns remained low compared to the activity in the rest of the trust. FFP test results have remained high in terms of the friends and family test reports of patients receiving good care, and there's a number of initiatives included in the report in terms of things that we've done differently. So one of those is a health passport for patients with learning disability. We've updated that in relation to including some of more personalised care needs that they may need. We've updated a hospital leaflet so they understand how to access the internet and video connections to that. We've implemented some smiley face cards as a different approach to gathering patient feedback, particularly in our children in care team. We work closely, and I was glad to hear that Healthwatch is coming on a regular basis to our board workshop, because we are building and continuing to build relationships with Healthwatch, so we understand more broadly what the feedback is from our public. In terms of concerns, we still continue to put some focus on improving the feedback and the rate of response for friends and family, particularly the number of responses that we get through A&E, and we're taking a number of actions to improve that. And we do have some concern about the response rate and the timeliness of that from our emergency division, but as you can probably appreciate, given the pressures operationally, that is a sort of balance of risk of how quickly we can respond based on the busyness of the hospital. But again, the emergency division have appointed some senior leaders in their division recently, and we're hoping that will improve that response rate. Apart from that, I'm happy to take any questions from governors on any aspect of the report that's been circulated to you.
That's great. Thank you, Fiona. And as I said, welcome back. Any questions or perspectives to Fiona? Okay, so thank you. I've been reminded, in his eloquence and straight forward manner, I failed to allow Glenn to cover off the quality assurance report. So we'll just pop back for a second. And Glenn, on the quality assurance report, was there anything you particularly wanted to pull out?
Yes, so this is the quarterly status report of the performance against the trust objectives, and those of you who follow the board meeting will have seen this anyway, because it went to a recent board meeting, but this will feature in the annual report, and it closes down the objectives that were set for last year. So the next time you see this, it will be looking at this year's objectives. And as usual, there's a RAG rating of whether we've delivered or whether there's more work in progress on them. The only thing I just wanted to point to, which is the kind of red rated area, which is making more progress on the lead provider responsibilities linked to the integrated care board arrangements. We've red rated it because we were keen to go faster than we have. The thing that will help us with this is that we are a provider collaborative innovator site, and they will be helping us and the system nationally to move that forward and to get around some of the hurdles, either real or perceived, that have slowed us down so far. So that's the only thing I wanted to just flag. Otherwise, some really good progress on lots of things, including quality initiatives like the autism strategy, like the cancer care navigators, and so I'm happy to take any questions if there are any, Russell.
Great, thank you, Glenn. Any questions to Glenn on those areas of assurance? I think one of the other things, which obviously isn't on that list, is again, for members of the public, we are doing some really great work in terms of driving to net zero, and we have been successful with our SADC's proposal, which means that by the end of next year, 80% will be 80% towards being net zero on the Warwick side, which is a quite remarkable result. And well done to all of the estates team for their development in that regard. We'll therefore move on to the clinical governance assurance report, and David Spraggett, who chairs our clinical governance committee. David, over to you.
Thank you. I think these are the reports for 3 meetings that, because of various reasons, have all come to this for this particular meeting. The one thing I would like to point out is the January meeting was considerably abridged because of the operational pressures that were in the system in the hospital. So a lot of clinicians weren't invited to attend. So there was a number of reports were read but not actually discussed. I think I don't wish to go into any great detail other than what's actually in the report, and I'm happy to answer any questions people have.
David, just because I think it might be of interest generally to members of the public, both you and I are champions for maternity services.
Yes.
And we've recently had a CQC visit.
Yeah.
Based on your independent view, how do you see that having gone and the level of assurance you have over our maternity services?
I mean, I have to say it was discussed at the clinical governance meeting as in yesterday, so of course that hasn't yet gone to board, so it'll be at the next council governance meeting. That, but actually the gut feeling is it went really well, and I think the staff actually had a positive experience about something that was quite stressful, I think, for them. And the feedback that we received, and it is only initial feedback, I think it'll probably be a number of weeks before we get the formal report, but the initial feedback was almost all positive. They did make some recommendations which the team are already addressing, so I think that we should take some comfort, and certainly compared to some of the reports that have been for other hospitals in the country, because of course CQC are visiting all maternity units in the country. I'm quite confident we will not be in the bottom third of that particular league table.
Thank you, David. So any questions to David as Chair of Clinical Governance on his reports and clinical governance matters generally? Please raise a digital hand. Mary?
Yes, David, is there any update on the situation with the mortality data?
Yes, there is. Again, this is something that was discussed yesterday, and so I think that the clinical governance meeting before last, Charles gave a very in-depth discussion about the various mortality indicators and explained some of the difficulties of interpreting them, because of course they're all looking backwards, they're not looking forwards, and they're certainly not real time. And of course I have heard that the most recent shimmy has gone down, so there has been some work that has happened over the last couple of 3 months, which we were anticipating was going to make a difference in a few months' time because of the nature of shimmy in particular, but it's hopeful that there has been a modest improvement already, which is possibly earlier than we might be expecting from the interventions. Okay. I don't know if does that answer your question, Mary?
Yes, it's heading in the right direction.
It's heading in the right. I mean, it's certainly not as the level it was 2 years ago, but it's stopped going up. It's probably the most important thing.
Thank you, Mary. Thank you, David. And Ruth?
Just adding on to this, which is a bit cruel, really, but because there's an increase in mortality, I read that there was congestion in the mortuary, and that sounds a bit horrible. That they were having a bit of a problem there. I don't know. Anybody
mortuary issues have not been raised at clinical governance, to be perfectly honest. I don't know, Glenn's got his hand up. I think he might know more about it than me.
Yeah, in the height of the winter with the flu and COVID, and let's not forget we had the biggest wave of COVID in that period. Pretty much all NHS mortuaries were full. And we therefore exercise contingency plans around using space in local funeral directors, etc., to minimise that. So yeah, I mean that was an issue, but we balanced it well and worked well across the system to address that issue. And some of it was a little bit related to delays in funeral arrangements over bank holidays when you have that period as well. So yes, that was an issue, but it's certainly not an issue at the moment.
Is there any plan to replace the mortuary with a more up-to-date building when we're doing the refurbishments?
There currently isn't. I mean, we are spending some money in there, but it probably would take me to the kind of wider point about access to capital and prioritisation of capital. And at the moment, even though we talked about the building works going on outside my office, the next big priority for us would to be make sure that we do resource the full theatre replacement programme.
Thank you.
Thank you, Ruth. Thank you, Mary. David, I guess a question for me. Clearly for our citizens, fast turnarounds of cancer tests, diagnosis and services is a disproportionate area of anxiety.
Yeah.
How are you seeing our cancer services at the moment, particularly as we rely on partner organisations for the provision of much of our cancer capability?
Yeah, I think the biggest issue we are having hitting the targets we'd like to achieve is third party issues rather than Swift issues themselves. You're quite right that we are constrained because we aren't tertiary units, and many aspects of cancer services do involve, even if it's only briefly, tertiary services, and so we do rely on colleagues in other hospitals to provide an adequate service. In terms of the diagnostics, we do provide most of the diagnostics ourselves, but there are again some specialised diagnostics that require tertiary expertise. So I think that as far as I'm aware, the service level agreements that we've got with tertiary units for this are being looked at carefully and discussed. I'm not the right person to ask about that, but
yeah, I think though, just in terms of making sure that as chair of clinical governance, you're feeling comfortable going forward, so if you like, executive conversations develop, I think is important.
Yeah,
and,
I think you're quite right. I think we're going definitely in the right direction. That's again. But as with many things, because we aspire to be, we realise we're never going to achieve exactly what we want to aspire to, because we're always aspiring to be better. And I think that we're going in the right direction.
Thank you, David. And finally, Roger. Then we'll move on.
Thank you. On the question of radiology results, is there scope for us to do more with AI internally to reduce our reliance on our partner organisations?
David, would you like Glenn to answer that?
I would love Glenn to answer it, because I'm unaware of the answer.
So Glenn, what would your view on Roger's
and the answer is yes. So we have been looking at some AI linked to radiology, and we're doing a little bit of a trial in George Eliot on that at the moment, which we'll learn. The learning from which will be shared across the group. There's an opportunity to filter plain film images, particularly through AI, so that the consultants look at the things they need to look at, and that looks to be going quite well. So yes, that will definitely help, Roger.
Thank you.
Watch this space, I think, Roger and colleagues. Okay, if we're feeling comfortable, we'll move on then to the finance assurance report. And Kim, over to you.
Thank you, Chair. So this is the outturn report for the last financial year, and pleased to report that we delivered a small surplus of £70,000, which is in line with the forecast that I've been presenting for the last few months. We have now submitted our accounts, which we submitted on time, and our auditors are, have been on site now for the last couple of weeks, and had an update meeting with them earlier, and the audit seems to be progressing on target. So that's good news. Pleasing to see as well, in terms of the month 12 position, that the percentage in terms of our agency spend as a proportion of a substantive staff is reducing, and early indications as well for our month 1 position also indicates that our run rate on agency seems to be heading in the right direction, which appears to be positive news. In terms of capital, we did spend £42 million on capital, a significant amount of spend in the last month as forecast. A big chunk of that, 26 million, related to the shares that we bought in Innovate as part of a significant transaction that we sought approval from the Council of Governors at the last meeting. The Council of Governors had given us approval to purchase up to 22 million, but also gave delegated authority to Glenn and myself to agree the final amount, which outturned at 26 million. And we also sought board ratification of that sum as well. So that was all done and agreed. The focus now really is moving towards next year, and we've got obviously my next paper is around our Excel and everything board. We've been doing a lot of toing from an ICB perspective around agreeing the actual plan for a new financial year, and we have negotiated the plan, which is a break-even plan for the trust, but that requires us to deliver a £20 million cost improvement programme, of which we've managed to reduce down to 14.5 million, which I believe is much more manageable as an organisation. But I'll pick up on the next paper around what we're doing around our approach to CIP in a minute. So if I take any questions really around the finance assurance paper now.
Thank you, Kim. Any questions or perspectives to Kim? Nice comment in the chat box from Mike. Thank you, Mike. Okay, I can't see any hands raised, so we'll move on then to the approach to the year ahead, particularly on CPIP, the cost and productivity improvement progress. Over to you, Kim.
Thank you. So cost improvement is always a challenge for any organisation, and we've kind of over the last year or so, we've kind of been brainstorming really a different approach, really to truly get the organisation engaged in our approach. And as Glenn alluded to, we wanted to make sure really that we ensure that we balance the quality aspects as well as the operational delivery, as well as the productivity and then delivering on the financials. So between us, we've come up with a programme on our cost of productivity improvement programme, but we've called it, we've branded it, shall we say, Excel in everything. And it's really pleasing really to hear that there is really good engagement, both culturally and as well as just general engagement really in the whole programme. So we've so Sarah Moppet, who obviously was the interim chief nurse, is staying on to support us, and she's leading the programme as our Director of Recovery and Care Excellence. And it's really good actually to have Sarah on board to be able to keep oversight and work with the executive team to ensure delivery. So I won't go through the detail. You've got the paper there, so it's supported by our programme, our project management office, and we've got a number of key work streams which I've set out in the paper, and we've also in addition set some stretch targets around agency reductions as well for the division, and we've got as a senior responsible officer leads for all of those programmes of work, and bringing it together and having a regular dialogue. The governance for those meetings that we have we have a board which reports through to our management board. I will obviously bring a summary in terms of how we're doing as part of my financial assurance paper, and we will also ensure that the governance is met through our finance and performance executive as well, to ensure that the bottom line cash is coming out as well, to ensure that we deliver our financial responsibilities as well, to deliver our break-even plan here. So happy to take questions.
Yeah, thank you, Kim. And at our 3 board meetings for the foundation group last time, we did talk about the opportunities across the group and within each of the individual organisations about really driving productivity and cost improvement. And there are still big numbers for us to go after. So I think it's excellent that Sarah's staying with us to help you drive this programme and it to be a truly bottom-up approach to accountability and delivery of better performance. So thank you, Kim. Questions and perspectives to Kim? This work is disproportionately important for us to ensure that we are driving the performance, the machine of Swift as hard as we can do. So we will keep you fully briefed on it. It's great that we do have that combination of Kim and Sarah involved in ensuring at board level that the work is successful, but we will keep governors and members of the public briefed as things develop. So we'll then move on to the, sorry, Mary.
Sorry, Chair, I can't fully understand how we got from the 20 million to the 14.5 million. I can't, looking at the paper, it doesn't look clear to me how we managed to do that. It's great.
Finances,
yeah, sorry if I didn't articulate it well enough. Right. So at the beginning of the year, we have discussions with the divisions around cost pressures that we will fund or not fund. You know, so I have to make some high level estimates at a point in time, which is where I got the original sort of gap of £20 million. But as we've progressed those discussions, I was able to close that gap down to £14.5 million. So apologies if I didn't articulate that well enough.
Thank you.
And then, as ever, Mary, there is a degree of jiggery-pokery when it comes to the way monies flow within the system. And so part of the reason Kim was able to do that was part of the jiggery-pokery, which I think is a technical financial term used by people of a certain ilk. Mike.
Jiggery-pokery indeed. I read the paper to suggest that the agency reduction target was separate to the 14 million target, and therefore you made the 20 million up that way. Is that correct?
No, so the agency reduction is separate because agency, we don't fund on agency. So from a budget perspective, we don't budget on agency expenditure. So any agency spend is deemed as a premium and contributes to an overspend position. So therefore, in order to ensure that we're not overspending, I've set very clear agency reduction targets for the divisions to equally make sure that they're managing within their means.
So that's a reduction to spending and not to budgets.
Correct.
Okay, thanks. Really clear.
Thank you.
Now, one of the things that's concerned us in some other people's numbers, Mike, is they're regarding a reduction in agency as part of their cost improvement programme, whereas in reality, it's just not spending money they're not able to spend anyway. So we've tried to be very clear and transparent on this.
Well, some budget for their agency spend, of course. So a reduction in it would be a saving on budgets, but I know we don't.
Okay, so colleagues, happy to move on to the audit assurance report from Richard. So Richard, over to you, please.
Afternoon, everyone. I think there's two audit committees. I think the 14th of December, 8th of February, but they were considered by the board on 1st of March and the 5th of April. I think a lot of the points I've raised, I think I've discussed with governors in various other meetings. The three areas that were really of concern, one was the fact that we're slightly behind with the managing of conflicts, interests and gifts. But that's because we put that online with the HR system, so we'll actually get better enforceability. So that's probably put back to April. We had some more delays on some of the satellite accounts, like charitable funds and Swift Clinical Services, but I can confirm to the governors they've all now been filed. And I have raised with you that like a lot of places post-COVID, there has been an increase in violence and bad behaviour and swearing, almost up about 80% to pre-pandemic. And there are mitigations being put in place there. I think it's common across most industry. People are frustrated post-pandemic and not very tolerant, but there's an awful lot gone into there. Happy to take the reports as read. Any questions?
Thank you, Richard. Any questions or perspectives? Roger?
Yes, Richard. Are the external auditors going to be able to deliver in a more beneficial time frame that, by comparison with last year's efforts, which frankly was a bit disastrous?
I think it was disastrous for two reasons last year. One was that there was illness, and two, when they brought additional staff in, their staff weren't at the sufficient quality level to deal with it. One couple of things, we've had a very good debrief between them and the accounts team, and also this time we've put a lot more controls around the questions being raised by them and making sure we're squaring off. And I'm sure Kim's going to jump in and just say it's all progressive, because they've had the numbers, and I think Kim said earlier they've had the accounts probably about 10 days now, and there's nothing that really causes significant problems. So Kim.
Yeah, thank you. Just to give you a bit of further assurance, Roger, I have a weekly meeting with their partner as well to make sure we're on track. We had a formal kick-off meeting earlier today to ensure that the work has been fairly distributed amongst my finance team, so it's not held up with one individual. And we've also talked about early escalation. If they're not, there's a strict timetable in terms of what they want and what we have to upload in terms of their electronic portal, and we are actively monitoring to ensure that we're submitting information on time. But equally, if they're not available, then we have dialogue around reprioritising that work to ensure that there is no dead time, really, I think, between both from their perspective as well as our perspective. So, but as I said, I've got weekly monitoring to ensure that we're on top of it. And where they have got gaps, they are bringing in more senior people as well. So we're not in the situation that we were facing last year.
Excellent. Well done.
And any other questions or perspectives to Richard? I guess I'd just like to go back on this issue of verbal abuse, just to make it clear. The absolute essence of our culture is to be kind and be polite. And we expect colleagues to be kind and to be polite to one another. But we also expect members of the public, their families, anyone visiting the site, to be kind and be polite. Everyone is working in a very stressful situation. We appreciate visiting a hospital, particularly if you're visiting a loved one, can be extremely stressful. But being kind and being polite is a basic requirement of you being welcome on the site. So we would encourage everyone to be kind and be polite, both staff and patients and their families. Andy Petros.
Thanks, Russell. On that very point, I'm just interested, have we had any incidents of bad behaviour, swearing, and if so, what are the plans or methods to stop that? Do we have a warning system? How do we escalate it?
I think
quite a lot of investment's gone in, shall I say that, Russell, to just go through, because we went through it in depth, trying to support the security and parking manager who looks after it. There's been another 6 cameras put into the emergency department, and key staff in the emergency department now have cameras and recording devices, because we found, and one of the problems we had was that we could record what was going on, but the actual verbal abuse wasn't heard. So that's now gone in, and staff are now, people who are abusive, sanction letters are raised on via Datix. So and we've also got more support to staff who've had that harassment. So I just think it's a feature of post-pandemic that the life is different.
Yeah, the standards shouldn't be. I agree with that, Richard. But about 20 to 25% of our staff report having been abused by members of the public in the last year, Andy. Glenn, anything you'd like to add?
Yeah, I mean, Richard said it there actually, but just to reassure Andy, there is a what we call a yellow card and red card system that is in operation. Obviously, it's a last resort, but we will occasionally withdraw treatment or arrange for a patient to go to another provider if they've been particularly abusive or violent towards any of our staff, and we obviously work closely with the police on that as well if we need to.
Thank you. Very reassuring.
It happens more frequently, Andy, than you would think. And even if it were to only happen once, it's unacceptable. But it happens a surprising amount. And I think it is, people can talk about it being a post-pandemic situation. For me, it's just about politeness, kindness, common decency, appropriate values for when people are doing their absolute best to look after you.
I'd just add to that, Russell, that part of the reason I'm raising it with the board and the governor is to make sure staff are aware that we all take this very seriously.
Thank you, Richard. We'll move on then to the reports and representatives on projects and groups. And first up is the Ellen Badger Hospital site redevelopment. Mike.
Thank you, Russell. So the paper was written a few weeks ago, but I'll take it as read. I did say that I'd provide a verbal update from yesterday's project board, and the interesting things of note were that stage 4, which is the detailed design plans, are now with the builders. Ground stabilisation equipment, which I'm sure is the sort of noisy stuff Glenn's hearing, is arriving soon, and we've got a planned start date this month. There was a meeting on site on the 27th with various trust departments where prospective teams came to look at the retained building, which if you're standing on the road looking at it is on the left-hand side, with a view to returning services while the actual building of the new section is going on. And it's planned to have a schedule of clinics available for the project board in July, so that's 2 months away. So hopefully by the time we get to September, we'll know what's going on and be able to say what services will be back there. An interesting challenge at the moment is Warwickshire County Council and the access to the site, which is going to be at the opposite end, so a whole new sort of entrance, has to be built by their preferred contractor, which I think is Balfour Beatty. So there's lots of liaison going on to make sure there's no delays on that at the moment. And the other point of note really is the Stour Health and Wellbeing Partnership are making excellent progress with Muna Chauhan, who's the Trust's fundraising lead. And she's already helped them get some new bids in for extra funding for the activities that are starting now, but will become the activities in the Health and Wellbeing Hub. Happy to take questions.
Thank you, Mike, and thank you for your hard work on that. And so questions and perspectives. John Holland. John, if you're speaking, we can't hear you.
Sorry, I've in trouble getting my microphone on, but yeah, just declaring an interest as the local county councillor. So I'm here to help. You know, if there will be problems. The county highways are very, very short-staffed because the private sector is paying a lot more for the same type of work, and inevitably there's a lot of things which should be done quickly are not being done quickly. But that's no excuse. You know, we need it done. So please give me a ring if I can be of any assistance.
Sure, I'll pass that offer on to Sophie. I think she was going to write to the appropriate person. It's all to do with the section 278 stuff. So
thank you, John.
Thank you, John.
And Mike Flaxman.
Yeah, we had about a 6 months delay getting the zebra crossing in Millers Road, but we got there in the end.
Yeah, we remember, John. Mike?
Yeah, I don't know if it's the right place to ask the question, but Stratford District Council Community Infrastructure Levy 1.4 million for the scheme. Where is that going to end up supporting?
Glenn?
I mean, it's probably a more detailed question than we've probably got time to answer it, but fundamentally, we are still trying to ensure that we can deliver an integrated primary care offer, as well as the redeveloped hospital on that site. So it would be a contribution towards that wider scheme, but there are still affordability issues for the primary care element. So I think that continues to evolve in the background.
It could significantly reduce the notional rent problems for the GP practice if it subsidised their part of the capital build, ?
Yeah, but there are then issues about subsidising what is a private business. So we just need to make sure that it pays appropriately for the right public benefit.
Seen it used before elsewhere for that, but I'll leave that one with you. I'm sure you'll sort that one out.
I mean, it is worth remembering that primary care GPs are private businesses, and any capital gain on property that they are involved with, any capital gain goes to the partners. It doesn't come back to the NHS, which is where we have to be very careful on this. If there are no other points to Mike, with thanks to Mike for your ongoing involvement, we'll move then to the end of life committee update. And Michael, over to you.
Well, I have prepared a report which everybody's got. I don't propose to go through that other than to say that it is clear from that report, I hope, that there are progress being made in various aspects, particularly 3 objects which the End of Life Committee is looking to improve in the coming year. And I was also pleased to see, as the ex-coroner of Warwickshire, that Dr. Raj Paur has been appointed as a medical examiner, because I retired as coroner some 15, 16 years ago, and we were talking about the appointment of medical examiners then, and it's very pleased to see that they've actually arrived. They are going to be a very good idea insofar as his job will be to oversee all deaths, more or less regardless, as against the coroner, and to see perhaps if we have amongst other things, a Dr. Shipman.
We certainly hope that's not the case, Michael, but point understood. Questions and perspectives to Michael on the End of Life Committee update? I would like just to again put on public record, we are and we have invested in a really high quality palliative care team. We have, I think, 2 palliative care consultants, and they do absolutely outstanding work, the whole of the team, on what is very stressful work. I am conscious of the fact that sickness levels amongst our team has been higher recently than is ideal due to some long-term sickness issues. So I would just like to thank all of the team for their continued efforts day in, day out to help people at the end of life and families coping with the knowledge that loved ones are at end of life. You do a great job. We're very proud of you and thank you very much.
Could I add there, Russell, as an observer watching professionals, that I've been impressed every time with the enthusiasm there is to actually make a good result for as many people as possible in those circumstances.
Well said, Michael. As often said, the 2 most important things we do are bring life, or should be, bring life safely into the world and help life leave the world with dignity. And at the nursing conference that we had on Tuesday, which both Fiona and I and Glenn attended, and Jean was there as well, it was great to see some of the celebrations of the type of work we do in the end of life area. So finally, Mary, then we'll move on.
Yes, Michael, did you make any mention about supply of end-of-life medication in the community? That was an ongoing issue for some time. I don't know whether that's resolved, or if it hasn't, perhaps that's something you could raise at a future meeting.
Emma, do you want to come in on that just for a second?
Absolutely. The urgent response community teams are working on this at the moment. One of the ACPs is championing it, that they will hold a bag of various drugs, including end-of-life drugs, that will be then available, so that if somebody needed antibiotics, end-of-life drugs on a Saturday on a bank holiday, they wouldn't have to be looking for a pharmacy, they'd be there ready to go. So that is a project that's been worked on and is hopefully near to resolution and implementation.
That wouldn't be allowed for the controlled drugs, so would it, Emma?
Yeah, they're held. The bags are kept in. That's the complication. The bags are being kept in. They're going to be kept in the community hospitals. So in like one in Stratford, some in Leamington, and then they're signed in and signed out as they're used by an individual.
I think it would be one of those areas that might be interesting for us to brief all governors on in the future.
Yeah, as it happens, yeah. Certainly it's been worked on.
And Sharon, then I'll just move on to keep the pace going.
Yeah, I just wanted to add in relation to Mary's question. We have 2 volunteer drivers working in the community in Rugby for the end-of-life palliative care team, who drive around picking up prescriptions from different pharmacies to support the families at that crucial time. We are looking to roll out across the whole of Warwickshire, and the feedback is it is such a crucial and very important service to support the families.
Thank you, Sharon. I think a lot of the problem, and this is what I think Emma in particular was referring to, is out of hours when we can't get into a pharmacy to get things. But it is great the work that our volunteers do, and it would be super to see that more widely available. Colleagues, happy to move on to falls prevention. So David, verbal update from you. How are things progressing?
Sorry, the meeting was only 2 days ago, so I wasn't able to put in a report. The figures for April were high, with one severe, but no contributory factor could be found. I mean, my personal view is that they are working very hard with training, literature, and so on, but it's not being really reflected in the outcomes. I mean, my view, and this is my personal view, is that really it's down to the acuity of the patients being admitted, the time of the year, the weather, pandemics, etc. So they could well be worse otherwise, but really you're never going to get the figure down significantly. They also published a 2-year report which compared 2022-3 to the previous year, which had a lower injury rate, but again this could have been down to COVID last year. That is very likely. The other document that was published was the down to the the patient safety incident response report. This is fairly lengthy, and if any governors would wish to see this, I can send them a copy of it. Otherwise, happy to take any questions.
Thank you, David, and thank you for the balanced view you take on things. I'm sure that the points you make are very valid. I recently had a relative on Fairfax ward, and I could see where patients were being strongly advised about not getting up on their own. Yeah. They were still getting up on their own. So it is very difficult for staff. The key thing is we are sure that we're doing everything we can. Sharon, if you could go on to mute, that would be helpful. Any questions or perspectives to David? Okie dokie. So thank you, David. We'll move on then to the patient experience group update. And Sharon, now over to you.
Yeah, sorry, I took the mic, put the mic on in anticipation a little bit early. So following on from the patient experience group meeting that was held on the 20th of April, apologies from Ellie Ward. The meeting was chaired by Sarah Reynolds, patient experience team manager. First off, the action log and matters arising were reviewed and updated. Sarah Reynolds gave an update on the patient experience group and PALS. The healthcare passport, which I think Fiona mentioned earlier, has not yet been agreed, but it is in the pipeline to be worked on with suggested amendments. The interpreting service at the hospital is being used. In March, the figures for friends and family was 93.4% of people saying they had a good experience, with the trust target being 96%. There were 23 formal complaints logged in February and March. The main areas were clinical care, appointments, communication, and a small number in maternity. Patient surveys, Beth Goddard during the meeting didn't actually give a presentation, but they announced that an update will be made once a quarter, and at this point there weren't any updates because it's been in the process of being relaunched and focusing on inpatients and maternity. The AHP update, one person attended from dietetics, her name was Charlotte. They did say it'd be useful to have more regular attendance from other AHPs. Sarah Reynolds added in that I Want Great Care will be changing to another company which uses electronic devices to send texts and messages to patients for their review. Patient forum update, Chris Thornton, the chair, was very sorry to announce the passing of Charles Hart, the former vice chair for many years. Kevin Smith and Michael Piper are covering the role of vice chair at the moment. Chris Thornton is working with Sarah Jane Fraser to arrange for all the patient forum notice boards at Warwick, Stratford and Leamington to be updated. Ward accreditations are being carried out throughout the trust and feedback is sent to hotel services and catering. Now my favourite part, volunteer services. An update was given by myself and Denise Phipps. We still have lots of volunteer applications in the pipeline and are in the process of recruiting. We've got volunteers supporting the rollout of the kiosks in outpatients department to assist with the foot flow. 3 breastfeeding peer support volunteers are being recruited in the north of Warwickshire to support breastfeeding team in that area. And we've got another lady who's recently joined maternity here at Warwick. We have Sally and Bailey. Bailey's the therapy dog and Sally's is human. Kate and Luna are visiting Warwick Hospital once a week. We are looking to recruit more therapy dogs. Alison and Bramble visit at Leamington Spa regularly, along with Kate and Luna, have won an award at Crufts for their amazing support to the patients and staff here at Swift. We have a fantastic volunteer team at Leamington, which sits with the MDT and is a core part of the team there. Volunteers. We are currently looking to recruit wayfinding volunteers to assist with whilst the building work is being carried out at Warwick, and to assist whilst the building work is being carried out at Warwick Hospital, so that we've got people on the ground actually directing and walking people to their appointments if necessary. We're currently looking at another sort of high-vis type some sort of uniform for that, so that they do stand out as wayfinding volunteers.
Need to watch the time a bit, Sharon, please.
Okay, all right. Well, I'll move swiftly on. Jane Downey, Legal Services, introduced herself to the meeting and explained what her role was at Swift. Gareth now also talked about ward accreditations, which are known as Care Excellence. These are taken out by a number of various different people from across the trust. Kathy Wagstaff from CRU gave a short presentation to highlight the difference between CRU and Fowden wards. CRU is for patients who have had a brain-acquired injury, and Fowden is part of the stroke pathway. Nigella Dean gave an update on the bedside folder to say that it needs a bit more tweaking and some more work done in it before it's finalised. Kathy asked if it could be shared and amended to suit Leamington. And finally, Manaki Chowan, fundraising manager, spoke about the latest fundraising events and that they are looking for volunteers to support these events out in the community to raise money for the Swift charity. Thank you.
Thank you, Sharon. Very comprehensive. Questions and perspectives to Sharon? Mike, I think there might be an opportunity for your new Springer to get involved in the pets therapy scheme if you want to do your best there. Not sure Spring is the ideal dog for pets therapy. Far too happy and waggy of tail. Sharon, thank you very much for your hard work. We are very, very blessed to have the volunteers we have. And we were all saddened at the loss of Charles. A number of us were very close to him and worked closely with him for a long, long while. And he was a great ambassador, not just for the patient forum, but for the role of volunteering.
Sorry, Russell. Sorry, I didn't raise my hand. It's Callie. Sorry. A very quick question to Sharon. Very quick one. Sorry.
Yeah, after you, Callie.
Just you talked about plans of the volunteering service to call patients on waiting lists. Is that to what would that mean? To tell them that when they're going to be seen, or how could they help people on waiting lists? That you mentioned, that's something that just
yeah, that is something that is being looked at, and it's called waiting while calls. So the idea is that we would have a small group of volunteers working with a specialised area, say for instance H&I unit, and they would call the patient to check where they were on the waiting list. Had they had any problems? Does it need speeding up? Do they need any more support whilst waiting? Did they have private treatment and they need to come off the waiting list? So that is something that's being looked at under the umbrella of the health and wellbeing care centres.
No, that's great. Thank you. Thanks.
Thanks, Callie. Apologies, I didn't see any hand raised. Thank you, Sharon. And we'll move on then to the Patient Safety Surveillance Committee update. And Sue, over to you.
Hello there. Yeah, the report I've got is from the meeting of March, so I'm not sure if that's the one that's already gone out before, but I'm happy to go through it. The meeting for April and this month were cancelled. Won't keep you a moment. Right, so this is a report of the meeting of the 6th of March. The patient safety.
Sorry, so you can, and all colleagues, you can take the reports as read. We will have read the reports. I guess I was
hoping you'd say that. It's on the whole, it's pretty good. The PSURF introduction for the new PSURF system of recording was going forward, but was not as fast as as they thought it would happen. There were financial implications for training people, and there was going to be a group of people within this area who were going to be looking at PSURF to see actually how it could be implemented and whether we needed to actually retain the DATIC system. But any other questions, please do come back to me.
Thank you, sir. Questions and perspectives, Fiona?
Yeah, thanks, Sue, for your attendance at that group, and apologies that we've had to cancel it a couple of times. Just on the back of the PSURF, which is Patient Safety Incident Response Framework, it's a national new patient safety incident strategy. I think it would be helpful for the governors and public to understand in more detail, and I'm happy for one of my team to do a presentation on that, because it fundamentally changes the approach to investigating incidents. And much more focus on the patient, the family, the public engagement in that, and asking really telling questions as to why you think it happened to you and how you feel about that. We will be recruiting some patient safety champions, which will be the members of the public or governors, which we would really help us to properly embed this very different approach for us. So I'm happy to come to a patient care committee, probably is the best forum to do a presentation on that at some point.
Thank you, Fiona, for that offer. And
Russell, could I just, sorry, Russell, it's Sue. I just wanted to say thank you to Fiona. It's lovely to have you back. And you explained that far better than I could or did. So thank you.
No problem.
Thank you, Sue. Any other questions or perspectives on Sue's update? I guess the one thing, Sue, and this is now directed at Fiona, the one thing that concerned me was the pressure ulcer data. Since the report's been done and since you're back, Fiona, is there anything on pressure ulcer trends which causes you an anxiety?
I have asking my team to do a deep dive into the ITU ones. We seem to have had an increase in pressure ulcers in ITU, which is unusual. And I think some commentary that it's not unexpected because of how sick they are. But to me, it should be unexpected. So I'm asking them the reasons for that and what we need to do to prevent it. But that's the only trend that has been different since I've been away.
Okay, thank you, Fiona. Please keep us briefed on that, because pressure ulcer is a nasty lead indicator if it starts to increase.
Yeah.
Okay, team, shall we move on to the Safer Discharge Group update? And Jean?
So we had a meeting yesterday. We've been meeting every other month. I missed a few over Christmas. So I'll take it as read, the report, but I need to update you. Yesterday's meeting was very energised. They were all really keen, and it was a delight to attend, to be honest. We've just received a proposal for a ward technician, a business case, actually in writing. They'd only just received it. And I said it was absolutely brilliant. And then it was pointed out that they didn't actually know for sure whether it was two technicians for Swift, one medical and one surgical, or whether it was one for Swift and one for George Eliot. So we will make sure that we find out about that. And obviously we can't wait for the business case to go through and for it to be implemented, because the pilot was so successful, and it's one of the main areas of concern is making sure it wasn't me that mentioned the fire service. They suggested that in October, if possible, but they can move the month, that we have a board to ward discharge event, and for Swift to include the fire service, the 4 staff, emergency department, A&E, whatever the public want to call it, and other people, so that we have a big event about discharge and raise the profile of discharge. Sorry, did somebody?
No, I just coughed. I apologise.
Oh, sorry. The respect form. They obviously want to try and have a solution, because it's not fair that nurses have to keep taking them home, and the volunteers, etc. So they're suggesting what they call an ICE bar, which is the integrated care model, where they have a new flow chart but more structured and similar to criteria-led discharge. So not just nurses' responsibility, but also junior doctors and, you know, whoever else. Sorry, I don't get calls. It's a garage. Sorry, where was I?
You're by a car now, aren't you, Jane?
Yes, criteria-led discharge, where the responsibility is shared. Just one process with shared responsibility to include extra checks and flow charts. We would have had a flow chart available to show you, but due to sickness of the person who's actually done all the work, we haven't yet got that available. So it will be available. And then we talked about olden days, and I didn't bring it up first, where we actually have a discharge checklist. Silly as that sounds, when we've got all this technology. And it was the nurses who talked about it and suggested it. And they actually go through where all the things just before the patient is thinking, of being discharged, that you go through everything with them. And one of the nurses said they used to do it on a paper towel that they pinched off the wall, because it's so important that they actually did do a checklist of all sorts of things, whether it's jewellery or, how they get, just all the things that are necessary. So so they sort of agreed about that, but obviously they'd want to discuss that with Fiona. But one of the problems about volunteers taking the TTOs where they weren't ready at the time is sometimes the patients will say, well, what's it for? And will it go with my other patients? And what is this tablet for? And of course they don't know, and it's quite stressful for patients and volunteers. So
watch the time a bit, Jane.
Sorry, the checklist will include that. They were thinking they'd have a big poster on the way out the ward, which also had a list, so that would remind them. So, as I say, it was a really energised, and there was lots of other discussions, a really good meeting, and I was very impressed.
Oh, that's great. Thank you, Jean, and thanks for all the work you're doing also on the A&D audit. Not too sure we need to be going forward with using TALS as a recording mechanism, but that's something for the past. Any questions or perspectives to Jean on her written report or her verbal update of the meeting this week? Okay, thank you, Jean. So we, of course, Kim, thank you. We'll move then to the patient portal group update. Lots of good work going on here, Roger. Over to you.
Thank you. I produced this because Pat was unable to attend the meeting. It's, I think, self-explanatory. Some of the work will slow down because of the potential delay in moving from Lorenzo to Cerner and the need to have the electronic patient records all in one place at the same time, because the feed for the patient portal picks up from our records. But I leave I'm happy to take any questions that you may want.
Great, thank you, Roger. Thank you for your work on it. The patient portal has been far more popular, I think Glenn will agree with me, than we originally anticipated. Any questions or perspectives to Roger? Okay, thank you, Roger. So that nicely segues us into the wayfinding strategy group update. Roger, back with you.
Thank you. As Glenn and Sarah have already mentioned, work's going on outside. This, of course, messes up the entirety of the signage one way or another. So there is an awful lot of effort that is going to go in, and Sharon's volunteers obviously will be helping. It's a matter that will progress slowly as things physically develop on site, and until we've trialed the way of getting people round, problems will occur. I'm sorry, we're working as hard as we can to make sure that there are suitable signs, and the car parking implications. I think there are some disabled slots that are being moved round simply because the contractors need the current space. So it is a fluid thing that everyone will be working hard on.
Okay,
Happy to take any questions.
Thank you, Roger, and thank you for your work on it. It's a very important piece of work, and for the future, just like to thank Sir John Egan for introducing us and me to Living Map. Mark Jones and I have had a conversation with them about how digitally we might be able to help the whole issue of getting to the right place in what is not an easy site. Any questions to Roger? Okay, thank you, Roger. And we'll then move on to the elective care group update. Graham.
Yes, thank you very much. You will have had in your pack a very detailed report produced by Mark Jones. I think that gives the detail. I'll take that as read. So that was based on the meeting in March. We've had a meeting in April and there is one due next week. I think one thing that has come out of this is how complex it is. A number of people have mentioned the noise and what have you, but that's not nearly as bad as what people are having to go with organising all of this, and I take my hat off to them. It's very complex. One of the risks, there is a new risk that's come up. There was an incident over a weekend when a contractor was excavating and didn't work to his health and safety plan and managed to hit the gas main. So that is being reviewed by the team as to how the level of supervision is probably increased at weekends or out of hours. That's all I've got to say on it. It seems to be going in the right direction. At the last meeting, we did see an artist impression of the finished building, which I'll make sure comes to the group next time.
Thank you very much, Graham. Questions and perspectives. Mike?
It's just a comment, really. The on sustainability, the BREEAM Excellent target is a very tough ask, but I do assume that once it's sorted for the elective hub, it will be useful in terms of taking forward BREEAM sustainability issues for the next phases of the hospital development. Graham, we'll be able to carry some of that forward, I hope, because it's pretty difficult.
Yeah, yes, I appreciate that, whether it's bat boxes or collecting wastewater, but in order to get the business case through, you do have to achieve that BREEAM Excellent, and that will fit in with the sustainability going forward.
It's really not easy. Been there twice.
Thank you, Mike. And Roger?
I think I'd like to congratulate Warwick District Council vicariously for being able to deliver the planning permission in double quick time. Thinking of all the hassle that we had in delivering planning permission for the car park, Graham and the team and Mark Jones, etc., have done extraordinarily well in getting it through as quickly. So well done.
Well said, Roger. Thank
you.
Well said. And thanks to all the executive team who are making the hard work happen. Colleagues, happy to move on. So just a few governance matters, which I'll try and rattle us through. The first is the minutes of the Patient Care Committee from the 13th of March, which will take as read. Jean, anything you wanted to add to those?
Really, I did do a proper report, but the minutes are much more up to date because of various reasons. So no, anything they want to know, but yeah.
Okay, thank you. And just for clarification, so correct me if I'm wrong, these are just for noting, not for approval?
That's correct, Russell.
Thank you. We've then got for noting the GPC approved minutes from the extraordinary meeting held on the 14th of March and draft minutes from the meeting held on the 13th of April. Mary, anything you wanted to add to these?
You know, take them as read. Just to explain, the extraordinary meeting was necessary because we had to fit in with the timing of the round table. We needed to have a discussion about the round table agenda, and we wanted to approve Mike as a member of the group so he could attend more quickly. And we had some urgent training issues that we needed to resolve. But then the ordinary meeting just covered the ordinary topics that we always have to cover. There's one thing that the Chair asked, that if governors are sitting on groups or committees that are not happening, could they let the Chair know? And then he'd like to know what's happening, because we've had a lot of meetings cancelled, understandably, possibly recently because of the pressures. But the Chair asked me to remind governors to let him know. We discussed the Membership Engagement Committee and the terms of reference of the GPC, which we're coming on to later. And we confirmed Carolyn as a member of the Radiation Protection Committee with Callie as a deputy. That's all I need to put out, I think. Thank you.
Thank you, Mary. Any questions or perspectives to Mary? Okay, thank you, Mary, and all your hard work as lead governor. And so we've got a report on resignation and appointment of governors. Sarah Clett.
Thank you. So since my last report, Dr. Bernard Usselman has been elected as the staff governor for the medical and dental category. We do still have a vacancy for the staff governor in the nursing and midwifery community, which we will go out for an election process in due course. I'd just like to note under this item that due to the recent local elections, we may have a change to the 3 appointed governors from our local councils. Decisions will be made by each of the organisations at their full council meetings this month, which then I'll be informed of the representatives who will be then our appointed governors. I'm happy to take any questions. Thank you.
Thank you, Sarah. And I'd just like to thank those stakeholder governors who may no longer be working with us going forwards for their hard work over the years. Questions and perspectives to Sarah, Mary?
Just to say that we all need to have some kind of induction in place for if there are new appointed governors. So we'll have to look at that at general purposes. Yeah,
absolutely. Okay, team, so we'll move on then, I think, to the draft quality report for 22-23. We'll take this as read, Fiona, but anything you particularly like to point out?
No, just the purpose of it coming here really is to receive comments from the governors, particularly on the contents of it. We do have a lot more freedom with the quality report now, post-COVID. Really, it's not there isn't as many mandated fields. In fact, it's not mandated to publish a quality report at all, and several organisations decided not to, but we have continued, but we have made it much more succinct and taken out some of the mandated fields which really didn't reflect the quality of our services as best we could. But we do have freedom to add things in if you think that anything is missing or want to send me any comments. It will go for approval to June audit committee and then July board. So you've got that sort of time frame if people want to send me anything.
Yeah, can I suggest the way we handle this is that if you do have any feedback on the report, you sort of email Fiona directly, and can I suggest you do that by the end of next week, because June will be on us faster than you think. Any other questions or perspectives, Mike?
Just a quick one. I think it reads very well, actually. It's rather good. Just a question. When will it go to Health Watch with my other hat on for them to review and comment on it for your Annex 1? I
think, and I might need to be corrected, Mike, but I think it came here first and then it goes to external partners. So it was coming to our internal sort of governor for comment first, and then it goes to them. So I think in the next week or two.
Thank you very much.
Okay.
Okay, so until Friday week to give feedback to Fiona, I'll forever hold your peace. Thank you to the team who have produced that, Fiona. Can you pass thanks back to them? Yeah. Then we've got the Register of Governors and Governors' Interests annual review. Sarah, back with you.
Thank you, Russell. So just to note the earlier comment around Pat Scott's updated interest that a grandson is a physiotherapist at the Trust and granddaughter is a primary care network manager in Coventry. And obviously the registers will also be, or may also be affected by the appointed governors once we've been notified of the representatives from our local councils. So I'm proposing that although these are published on the website, that until we've got the confirmation of the appointed governors, I will postpone publishing them for the time being. So these are for receiving a noting with those caveats. Thank you.
Thank you. So any questions or perspectives? Just a couple of points from me. I would always counsel governors, as I do myself, to fully declare any interests they have, any business interests that they have, because then it's just a matter of public record and you don't have to worry about any item coming up needing to declare stuff. So I'm surprised just with some governors that a few nothing to declare as well. I thought you would have had a business interests or other interests elsewhere. So I leave that with you. My second observation is it is for some strange reason a obligation on governors to declare their I was going to say allegiance, but their membership of any political party. That doesn't hold for non-executive directors, which I've often find a bit strange, but just for the avoidance of doubt, I am not a member of any political party, nor have I been. I was for a short period of about 3 months a member of the Communist Party at the age of 19 as an enthusiastic young student at the age of 19, but I met some of my fellow members and decided shortly after that a pint of Guinness was probably a better thing to do on a Friday evening. But I'm not a member, nor have I been, of any political party, just for your interest. But I would encourage non-executive directors in their declarations of interest, if they are a member, albeit you're not expected to. I just think it's polite to governors, as they are expected to, mention if you're a member of a political party. Any other questions on the governor's interests? And so we'll move on to the Membership and Engagement Committee. Sue, over to you.
Hello. Thank you, Russell. I'll take the report as read, but I just want to pick out a couple of key points. Governors were asked to submit expressions of interest in joining the new Membership and Engagement Committee, but unfortunately there were insufficient numbers to meet the membership requirements as set in the first draft of the Terms of Reference. So at the General Purposes Committee, they therefore agreed some amendments to the Terms of Reference so that the establishment of the Membership and Engagement Committee could be recommended to the Council for approval today, and those terms of reference are attached to the report. And it should be noted that subject to the Council's approval today, the responsibility for membership and engagement will no longer fall to the General Purposes Committee. So the next item of business on today's agenda will be to consider an amendment to the General Purposes Committee terms of reference. I'm not sure if Mary wanted to add something at this point.
I think that was very clear. Thank you. Mary?
Yes, I would. Yes, as Sue just said, when we asked for expressions of interest to be on this committee, we only had 3 governors. So I would like to encourage, we've made the terms of reference quorum 3 to allow it to meet, but we would like more governors on board. We would like any type of governor. Particularly, we'd like to encourage, once we've established who the governors are going to be from the local authority, we would like to encourage an appointed governor from local authority, because we think it would be very useful to link in with the engagement activity of the councils. So once we know who they are, we'll perhaps write to them individually and ask if one of them would like to step forward. But equally, any other governors would like to make this committee a bit more robust, if we can persuade anybody.
Yeah, I think just to reinforce what Mary said, this committee is actually a key responsibility of the governors. And so I would really encourage governors. I know a number of you are busy, a number of you do different stuff. really important stuff. And some of it I know is very interesting and you find it very educational, but this committee actually has important governor work to do. So if I can encourage governors to join the committee, I would be grateful. I appreciate those who have volunteered already.
I think it's important, Russell, to add that we want all governors to get involved at some stage in the activities that are arranged by this group. But this is the group that's going to sort of steer the agenda. And I'm stepping back from that because I can't take on any more.
Yeah, no, absolutely. Thank you, Mary. If you're not happy to approve these terms of reference, could you please raise a digital hand? You take your digital hand down, Mary.
Sorry, just wanted to add that the first meeting of this group is the 31st of May, and the committee, sorry, and they will perhaps want to look at the terms of reference again. I think Mike and Roger have been doing some work on, particularly Mike, so they can take them away and the committee can bring them back to the next Council of Governors if they want to make any more changes.
As such, thank you, Mary. Did you take that's perfect. So if you're not happy to approve the establishment of the committee and its terms of reference, could you please raise a digital hand? Duly approved. And I think on the next one, if I can just help on this, Sarah, it's just that simple amend, isn't it? So yes. Amending the terms of reference of the GPC to reflect the establishment of the Membership and Engagement Committee. If you're not happy to approve the adjustment to the terms of reference of the GPC, could you please raise a digital hand? So they're duly approved as well. Thank you. We're then on to the annual review of board standing orders. Sarah?
Thank you, Russell. So the board standing orders have been reviewed by audit committee and also through the board, and because this is part of the constitution requires Council of Governors approval, there are actually no amendments being proposed, but they're here for Council of Governors consideration as to whether there's any amendments to be made this year. Thank you.
Thank you, Sarah. So the annual review of board standing orders, any questions or perspectives? If you're not happy to approve them, could you please raise a digital hand? Okay, thank you, duly approved. And then the update on NHS England's publications. Back with you, Sarah.
Thank you, Russell. So the report outlines recent publications from NHS England, which I felt the governors needed to be aware of. It includes a brief overview of each of the new publications together with hyperlinks so that you can access them and read them in more detail if you wish. So happy to take the report as read and answer any questions. Thank you.
Thank you, Sarah. Any questions or perspectives to Sarah? Okay, duly noted. Thank you. And then the Council of Governors schedule of business for the year ahead. Sarah.
Thank you, Russell. Happy to take it as read. It's for the Council of Governors to approve. So if there's any amendments that we know of at this stage, but obviously we can adjust the schedule as we go through. Thank you.
GPC does that. Any questions on that schedule of business? If you're not happy to approve, could you please raise a digital hand? Okay, duly approved. So I think we're on to any other business, team. Any other business, please raise a digital hand before we go to the confidential section. I don't believe we've got any. I apologise, Fiona. Fiona?
Sorry, I was late raising it. Can I just remind all governors and public to have their spring vaccines if they are eligible?
Thank you. Thumbs up going around. Thank you, Fiona. And have we had any hands back up, Fiona? Okay. And do we have any questions from members of the public? Sarah?
We haven't, Russell, no.
I can't see any members of the public on the line, but if there are members of the public on the line who'd like to ask a question, could you please raise a digital hand? Okay, just for members of the public who in the future may be watching this, if you do want to ask a question, please do not hesitate to email me at Swift, and I will endeavour to answer it. All questions are always welcome. We will therefore adjourn to discuss matters of a confidential nature, but can I suggest we have a 10-minute comfort break, get back together again at 4, and then we will go on to the confidential section. Thank you very much, and I will see you in 10 minutes. Take care.